Hello everyone, this is Yannis Skalkidis talking. We're going to start with the quality and patient safety, a huge issue. We are not expecting to touch all the aspects of those two huge domains, but we hope that we will touch on some of them, the key ones, or maybe the most controversial ones, and based on these points, we will be able to have a quite fruitful discussion, especially in September. The ancient Greek philosopher Aristotle has said that we are what we repeatedly do. Excellence, then, is not an act but a habit. Although I'm Greek myself, I would argue about this famous quote, as we still struggle to find out what exactly is excellence, since to know that something is a habit does not say to us what exactly is this something. We can be happy, though, that from the time we reach at the level of excellence, whatever that means, we should adopt it and make it our inseparable habit and not a one-shot action. So in other words, excellence is a habit and we have it or not, that's all. Let's try now to converge towards a defining starting point regarding quality so that we can claim that we provide high quality in healthcare, knowing what exactly we are talking about. The Agency for Healthcare Research and Quality in the United States has offered to us a quite comprehensive and meaningful definition taking into account the different perspectives of providers and patients. And so they say that providers should deliver the right care to the right patient at the right time in the right way. Patients can access timely care, have accurate and understandable information about the risks and benefits and so on. And both patients and clinicians have their rights respected. Great. But a provocative question for discussion in September about patients' role is the following. Do you see in this definition, but also in other definitions that are available in the literature, any notion of patients' accountability, their own responsibility and obligations? Don't you agree with me that it seems that the patients, the way they are presented, their role in this definition, they are somehow inactive, non-participative recipients of health services? What is ethically right and feasible to be done, if something should be done at all? In addition to the previous definition, the Institute of Medicine in the United States, again, has offered to us the following. Quality of care is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Are we happy with the word increase the likelihood? Is that enough for us, for the patients, for health professionals? Another issue for I would say, controversial discussion. Current professional knowledge. What are the hidden aspects in this statement? Are we sure what we're talking about? I would like now to bring to your attention Donna Bedian's provocative, challenging, but most of all, enlightening quote. Quality, he has said, includes whatsoever you think it is important for any side in the delivery of healthcare. When I've heard this quote from his own lips in a friendly discussion in Europe around 1996, I initially thought it was just an exaggeration, just a way to stress something out. But over the 20 years that passed by since then, I realized how true and verifiable his words were and how much light shed to a deeper conceptualization of what is quality in healthcare. Of course, Donna Bedian was adding that quality depends on whether contributions of health professionals and patients are included, how health and responsibility for health are defined, whether we seek for maximum or optimum care, based on which parameters optimum care is defined, and so on. So a crucial issue for discussion for us is to carefully analyze by which factors optimum clinical effectiveness is defined and depends on. This is the main issue for us to agree on. Let's touch now the patient safety. What is patient safety? The prevention and amelioration of adverse outcomes or injuries stemming from the process of healthcare. Sounds rather clear, right? But let's see if it is like that. Two are the key dimensions in the delivery of care: effectiveness and safety. Effectiveness is providing services based on scientific knowledge to all who could benefit, and refraining from providing services to those not likely to benefit. In other words, avoiding underuse and overuse. And safety, the other key dimension, is avoiding injuries to patients from the care that is intended to help them. So here we come to the old Hippocratic quote of Elaine imi vlaptin, which means to be useful or not harm. In my days in medical school, but also more or less nowadays, our teaching in the university focuses on the first part of the quote, namely how to treat our patients, how to maximize clinical effectiveness. The second part, not harm, although explicitly highlighted by the father of medicine, has been somehow ignored for centuries. Well, never is late, and we have eventually recognized that this is not just a saying, but a crucially important reality that deserves our utmost attention, equally with the first part of the Hippocratic quote, which is to be useful to your patients. But why we're saying all this? Rand Corporation in USA and Royal College of Radiologists from UK recently published data, statistics, more or less saying that 25% hospital days and clinical procedures were inappropriate, 40% of medications were unnecessary, and 25% of radiological procedures were not necessary. Needless to say also that those statistics can be much worse and quite frightening in some places, in some geographical areas. There are examples, for example, in countries where 2/3 of lab exams and 1/3 of therapeutic interventions are considered unnecessary. At this point, I would like to bring to your attention a recent study from Mayo Clinic, which was published last August, and they have examined and they have analyzed medical practices, thousands of medical practices, that they were categorized in two different sets. One was the new medical practice that were introduced in medical practice, and the others are the well-established medical practices that are used all over the world. And they found that out of the new medical practice, 77% were found beneficial, so they could replace the old ones. 17% were not beneficial, which is fine because not always were successful, and 6% were inconclusive. But the most interesting for us is the case where the established medical practices, out of them 38 were found beneficial, which is excellent, but 40%, a bit more than that, were not beneficial or even worse than not doing anything. Plus that another 22 inconclusive, out of which, of course, some were also not beneficial. So it comes out that more than 50% maybe, or let's say 50%, half of our practices are not beneficial for the patient, which is a really of crucial importance, and bring to attention to everyone this fact. And we also know that there are outmoded and inefficient medical procedures that they cost $390 billion. So it is not only that we are affecting lives and human suffering, but also we are losing a lot of money by doing that. Well, we could play a bit by saying a simple and easy way to be very safe. We can be absolutely safe by not doing anything, achieving in this way 0 complications and 0 adverse events. The problem is that we will also be 0 effective, clinically effective. Certainly there cannot be doubts about these arithmetics, but you can surely have objections about the concept of not doing anything in order to avoid medical wrongdoing. Thus, we should start calculating errors of omission, because this is what I'm talking about. But the poisonous strategy of under-treatment has already been introduced in our everyday clinical practice. Obviously, there is a golden balance between over-treating in an effort to maximize clinical effectiveness and under-treating in order to minimize the risk for the patient due to treatment. The ancient Greek quote of Metron Ariston, which means away from the extremes. In other words, the golden balance is, again, the same thing. We should better be not on the extremes of over or under treating. So I'd like to close this concept by just saying that clinical effectiveness, clinical hazard, and patient safety are some realities that they are so tightly interwoven that we really need to be very careful and very analytical when we're trying to see towards which direction we have to go, and where is the balance, of course. In the reality of the clinical world, we have to define what is a hazard. So is it the same thing when we talk, for example, about an inadvertent trauma during a surgical operation, let's say a laceration of vena cava? All lacerations can be different. It's like a continuum of the severity of the trauma with certainly different detrimental consequences and different rectifying measures to be taken. This brings on the table the semantics, the terminology, and it is extremely important to know and to specify and then quantify what is a risk. So in other words, we need a more sophisticated approach to view clinical risk in healthcare if we want to be useful to ourselves and to the patients. The risk in the healthcare is not always a categorical parameter. It's not yes, no. It is more a continuous one. And for each quantum of this continuum, for each DS of the risk continuum, a different probability applies. We cannot speak about a clearly defined specific one risk or hazard, but for many sequential quanta of the same risk when it is broken down into pieces. So more importantly, a different DS of this risk continuum, different risk drivers and impact drivers exist, taking different values, so the final clinical detriment may substantially vary from case to case, even if we are talking about the same risk that we have called, let's say, laceration of vena cava, as we've said before. And just for the sake of the discussion, especially from the theoretical point of view that I really expect to have in December, I think that we should just mention clarifying the notions of risk and hazard. A hazard is an existing situation that is likely to cause harm, and a risk is a potential situation that does not exist, but theoretically could exist. If the risk comes to existence, then risk becomes a hazard. And a good example is the surgeon who is a hazard, but not a risk. But when the patient decides to be operated, she or he is exposed to this hazard and takes the risk. And just for the sake of the discussion, let's just touch only some basic elements of the risk. So we have the probability of risk, and then we have to ask ourselves, can it be reduced before the happening? We have the hazardous event, and then we have to think about, can its intensity, its strength, let's say, be reduced or ameliorated during the happening of the event? And also we have the detrimental impact, which means that we have to wonder ourselves, how much of the detriment can be rectified after the hazardous event has happened? So a number of things can be done before, during, and after this hazardous, let's say, process. Based on what we've just mentioned before, there are two options for a risk. It is inevitable, which means will happen whatever we do. So the probability of the event is always bigger than a 0. And the other is it can be completely eliminated. So that means that there is a potential to achieve probability that is equal to 0. In the first case, the effort is, and has to be, to decrease the likelihood of the event to happen. So we should try the probability to minimize up to 0. In the second case, we should explore the possibility not to allow the contributing factors to appear, thus to eradicate this risk and achieve in this way a 0 probability. Let's now say a few words about the probability of a risk and the actual event. The puzzle of a risk in healthcare lies in its unknown probability and its difficulty to predict, this predictable detrimental impact. Is this the case in healthcare organizations? Well, there are new emerging risks, a rather small proportion, due to new technologies or new approaches, new methodologies and so on, and the old ones, the well-known risks. But the old ones, which are the majority, are conveniently helpful for us simply because they do occur every day, unfortunately often, during this day-to-day delivery of healthcare in all healthcare organizations. The question comes, can we accurately track the geography of clinical risks in a healthcare organization? Well, it seems it could be easy, but I argue it is not. Because it's like driving a car. Can you drive a car? Yes, no, it would be easy, but driving a car can be different by having a different car to drive on different roads in different weather conditions with different driver skills, because the drivers are different, and the same drivers also may be at different moods. So we may think it's easy to identify risk on the road, but let's think about it a bit more. Even more, this is the case in the delivery of healthcare. So keeping in mind the previous example of the driving a car and the different conditions of the driver, of the car, of the road, of the moods are different, can make a huge difference in our assessment. Look at this, what can happen, how can we assess a similar situation in the healthcare sector? We need to be very specific about the level of our analysis. Are we talking about the hospital, about the surgical department, for example, the surgical procedure, because there are different procedures in the same surgical department, the surgical team, not the surgeon, but the surgical team that he's working, the individual surgeon, of course, and the surgeon's performance over time. So all these can make a huge difference in the outcome and, of course, in the risks. So how can we monitor the detriment? Can we rely on hard facts? We do know the majority of hazards in healthcare. These are the adverse events. We can monitor their incidence, the probability of the event, the detrimental impact, the severity of the hazard, and consequently the total loss. We're talking about adverse events. Everyone knows. I just want to simply list them all in priority, let's say, of severity. And the first one is the hospital-acquired infection, as you know, the adverse drug events and so on. You can see in the list, but just to refresh our mind where we can first look, and then, of course, to all others. So we are facing increased risk, and we are pressed for accountability. Where all these two facts are stemming from. In the next 4 slides, I will just have put together the most important ones, and you can see, you can follow in red the technological advances, the consumer awareness, an increase in patient expectation, which is quite important, and this phenomenon is all over the world, and also that there are quality standards that they have been clarified through the accreditation agencies, and everyone knows about it, so they can be very picky about it. Also, it is the media coverage, which is much more than before. The use of performance measures for contacting and or accrediting, and of course the poor ability to predict clinical risk in many cases that it was were not so careful in the past about it. And finally, the depersonalization of the physician-patient relationship, which is extremely important for, especially for the patient, the increased claims and the different contingency fee systems for lawyers and the deep pocket laws and so on, which are making things even worse than the reality brings about. I've just put this slide with this diagram to make it more illustrative, but to every one of us realize how the situation can evolve regarding the clinical hazard. It can be, as you can see, from full recovery up to death, and there are different situations that deserve specific analysis, each of them, to reach to different strategies and potentially multi-targeted actions to prevent, reduce, or ameliorate the detrimental effects of the hazard. And here there's another diagram about the total loss from risks, depending on their severity and likelihood. And there is a question for discussion. What will happen if we turn horizontally twice this illustration, namely by 180 degrees? What are the implications for the organization if you act based only on the perspective that will be produced after this shift? The perspective of the total hazard of the various risks should be such that we can view the detriment of all the risks and not only of the most prominent ones, the gravest ones. And this is a very good topic for discussion as far as to regarding the priorities of what should be done in the area of risk in the healthcare organization. And certainly, I'm sure that everyone has headaches in trying to answer this question: which clinical hazard are we most afraid of? The catastrophic one, which means deaths; the most lengthy incapacitating, someone who is for a long time, maybe for life, incapacitated; those that incur the most severe suffering, the most likely to happen; the one that affects very high number of individuals, the most costly one; the one that may damage organization prestige; combination of all those, and in which specific way each of these choices, let's say. So the complexity of the issue is obvious, but still we do need to make a decision. So we have a question to discuss. Based on which parameters healthcare organizations develop their strategy and actions? And before we close, please don't forget, a crucial factor is not yet included in our equation. This is the contingency plan. And the question is how the contingency plan can transform our thinking, strategy, and actions regarding the hazardous health impact. It is also a very interesting topic that can be very helpful for everyone. So thank you, and see you soon in person.